Good afternoon. My name is Megan Huth, and I'm a research assistant at Benjamin Rose Institute on Aging. This session is being offered as a part of the Administration for Community Living Alzheimer's Disease Program Initiative Project, expansion of dementia-capable communities within urban and rural settings in Ohio using evidence-based and informed programming. Thank you for joining us today for Bridging Conversations between Intellectual and Developmental Disabilities and Dementia. Today's webinar will be recorded. During the webinar, you may submit a question at any time using the Q&A button at the bottom of your screen. We have staff monitoring the questions in the chat to convey your questions to our presenter and to answer any technical questions you may have. You can turn on captions by selecting live transcript, the button with two C's at the bottom of the screen. We are conducting an evaluation of our dementia education sessions as part of this project. You should have received an email with a link to the pre-session evaluation questionnaire, which also contains further information about the evaluation. If you did not have a chance to complete the pre-session questionnaire, we ask that you please complete this now using the link provided in the chat. By doing so, you are helping others in your community. Your responses and feedback will be used to show the impact of the programs like these and to improve the tools and resources provided to individuals living with dementia and the people who support them. I now have the pleasure of introducing our speaker for today's presentation, Kathy Service. Kathy has been a nurse practitioner since 1979 and has been working in the field of intellectual and developmental disabilities, or IDD, since 1976, both in institutional and community settings for the Massachusetts Department of Developmental Services, or the DDS. Although retired since 2016, she continues to consult as a dementia care specialist advanced practice provider on aging and dementia in people with IDD at DDS. She also continues to collaborate on administration on community living grants in dementia, as well as the CDC Healthy Brain Initiative grant with the University of Illinois, Chicago. Please join me in welcoming Kathy.
Great. Okay, thank you, everybody. And I'm really honored to be here. So next slide, please. So here are some of my disclaimers. And I think you all know that as I'm a nurse practitioner, so medically people, we always have disclaimers. And I've included them that really talk about my background and connections so you can understand the foundation of this presentation. And I also one I didn't put down is comment that the slides are jam-packed with information. So it was somewhat intentional because so you could listen, not scramble to take notes, but I'm going to be really just highlighting special points from each of the slides that I really want you to know or be able to clarify what information that may be meaningful for you to take back as you support people with ID who are either living with dementia or at risk for, or there's a suspicion of dementia. Next slide. So here's what we're going to be discussing. The point I want to make here is that we're really using a lifespan lens. And in terms of, as we know more and more, in fact, the Alzheimer's International has been meeting in Amsterdam in the past week or so, and more information is coming out that really talks about dementia being a lifespan condition. And that changes in the brain, especially with Alzheimer's disease now, may preclude the onset of symptoms by decades. And we know this, that with people with intellectual disabilities, particularly Down syndrome, we already know that, say at age 35, should they have a brain biopsy, they already show plaques and tangles, but they don't show it clinically, which makes them interesting. Next slide. So why? And this is, as I said, I'm friends. This is my friend Bruce, who's 82, and he still is working at a natural foods restaurant nearby. So using the lifespans lens, we'll start with age, because age is the biggest risk factor in the development of dementia. And for all of us, just as for all of us, people with IDD are also getting older. It's due for various reasons, medical advances, improved living situations, societal changes. Now it's going from like mid 50s to 70s as for life expectancy. But so pay attention to that second bullet point, because that really will give us some example of what we're going to have to contend with or deal with or address as the years go by. Next slide, please. So, but this is a great slide because it really demonstrates the remarkable increase in life expectancy for people with Down syndrome. Look at this. In 1900, the life expectancy was 9 years old. Come forward, by 1984, it increased to 28 years. And now the life expectancy of people with Down syndrome is about 60 years old. So that says a lot, and also has a lot of implication for us who provide care. Next slide, please. So we know the aging process is quite diverse and for various reasons. And so there's much of it in terms of what we can do, and much of this we need, but there are things that we can't change. So also when we look at this, we can see where there's connections regarding dementia, whether it's risk factors, the assessment process. And we're hearing more about health disparities, which are particular types of health differences that are closely linked to economic, social, or environmental disadvantages because of discrimination or exclusion. And I want to stress that people with intellectual and developmental disabilities are a high risk for health disparities. Next slide, please. And of course, this segue, it brings us to this notion of social determinants of health. And a lot of this stuff you're going to be hearing a lot, and we hear a lot more of in the news and in the literature. And this figure just illustrates it more. So there's some things, if you look at in the center of age, sex, and hereditary, that we can't change. However, as you branch out in this rainbow, you can see that there are a lot of community conditions, etc., housing, education, even higher societal conditions as wealth inequalities that really affect how we age and what goes on with us. And public health right now has been increasingly examining these areas for interventions. Next slide. So, and this is an interesting slide because it really talks about, it shows you that what can be done and what can be addressed. And the little figure on the right-hand side of the slide shows you where in the lifestyle we can look at and that if we can make intervention that will either mitigate or lessen the onset of dementia for people. So the point of this slide is that there are things that you can do at any time that will make a difference for you. And some people will say that, you can maybe even make a change in like 40% of dementias or so. So this is an important slide that important paper that came out in 2020 that talks a lot about what we can do and what we can't do. Next slide, please. So this is pretty jam-packed, another one. So this talks about health. So these are a summary of the normal biological changes that all of us have. And I included this to point out that, as we said, people with IDD are aging, and these typical changes. So how does this affect any of the people that we support? And then how will it affect our assessment for dementia? And also how we support each other, and these changes, I work a lot with older families. So if the older parent or older siblings are also being affected by these body changes, it has a little implications for the provision of support for the person with intellectual and developmental disabilities. And the last point, the homeostenosis is a new term that I learned about from a geriatrician who is actually in Ohio, Dr. Carl Tyler, and he works a lot with people with ID. And that's our bounce backness. And we know that those of us like myself who are getting older, things just take a lot longer to bounce back from if you have some kind of an insult or even in terms of falling, things like that. There's all this stuff in our life that we have to kind of work our lives around because it just takes a lot longer to do things. Next slide, please. These are another same thing, same implications for conditions. But so how does it affect people with ID relative with dementia? And the points here I wanted to kind of point out specifically on the bottom have to do that they have a lot of implications when we talk about other kinds of intellectual disabilities and risk factors for dementia. So first of all, secondary conditions, and they're defined as any additional physical or mental health conditions that recur as a result of having that primary disabling condition. And I first saw this in an Institute of Medicine report in the 90s when they talked about people with cerebral palsy and spina bifida, what we could probably expect from people in terms of physical changes in their body as they get older. And they are secondary conditions because if they didn't have the CP, they would not have these conditions to begin with. And then allostatic load and weathering are both newer terms. And an allostatic load is defined as the cumulative wear and tear on the body due to trying to adapt to adverse physical and psychosocial situations. And weathering is the same, kind of the same thing, but it's this repeated adaptation to ongoing stress that can lead to wear and tear, and it reduces the body's capacity to effectively manage subsequent stressful events. And kind of put, stress really causes our physiologic burden. And as a result, our body produces certain substances such as response to stress. This is like norepinephrine, epinephrine, cortisol. These are neurotransmitters. And in turn, that this oxidative and physiologic stress in turn causes things like elevated blood pressures, increased cholesterol, blood sugars, and more. And there are other conditions, even as changes on our chromosomes themselves, which really accelerate biological aging. And you'll understand a little bit more about this because as we talk about autism and cerebral palsy and whether or not they're at risk for getting dementia, this will come into play at that point. Next slide, please. This is just a quick slide about life expectancy, and I'm not going to be telling you about all the syndromes, but it gives you an idea. The one thing I wanted to point out, this researcher, who Tony Kopis, who published this, talks about cerebral palsy in 55. I know people with CP and who are somebody who's my age. So I think that what we have to realize is when you hear research, sometimes it really has to be examined carefully and also making sure that it's current. This researcher mentioned that they believe that the life expectancy is more, for people with CP, is more affected by the degree of the severity and the physical or cognitive impairment. The next comment, and look at this with the Down syndrome person, 82. And this woman died from complications of a fractured hip, which is much more has to do with being 82 years old. And while it's not common still, there are lots of reports of individuals with Down syndrome living into their 70s. However, there's a real dearth of literature on aging issues and dementia for people with IDD in most genetic diseases and syndromes, but we're amassing a lot of research on Down syndrome and a little bit more on autism spectrum disorder. So next slide. The other thing, but could you backtrack? I'm sorry, I forgot the other slide. So thank you. I just wanted to comment is about if the syndrome is rare, especially if it's continuing into older age is a rarity. And I wanted to give you an example. Recently I learned of a sister whose sibling is her 50s, moved in with her. Her sister has a specific rare syndrome and had been experiencing different changes in her behavior. And the sister, was like, what's going on here? So she had her evaluated. She saw a neuropsychologist, and the neuropsychologist told her she has Lewy body dementia. She's in her 50s. And so I looked up the syndrome myself because it was a rarer syndrome. And I found out that many of the secondary conditions of this person are reported with the syndrome actually had the same description as Lewy body dementia. But alas, the sister, and she wasn't a patient or somebody that I was working with directly, was so relieved first that somebody listened to her. And secondly, to finally have a plausible explanation, no matter how dire, of what was going on with her sister with intellectual disabilities. And sadly, then later she had neurology consult and they doubted that it was really Lewy body dementia. However, they didn't give her any sort of explanation of what they thought was going on. So where does it leave her sister, the caregiver, and where can she then get help? And that's the thing that I find nationally, that when people have these rare syndromes, as they get older, which now they are getting older, just like other people, what happens then and where can they get help? Next slide, please. Thank you. So Down syndrome, and look at all of these that are associated with Down syndrome because they figure greatly in the assessment and support of people when somebody has Down syndrome and Alzheimer's disease. And I just want to point out one thing here, that point about regression. And you can see it going down the bottom. And regression is a term that often gets diagnosed as Alzheimer's disease. And it's a term for a loss of previously acquired developmental skills in an individual. This can be in all areas of daily living, language, motor abilities, and social interaction. And it can occur over weeks, over months, quickly, and in time may the time course might help in determining the likely cause of regression. And I was just at a Down syndrome, the Down Syndrome Medical Interest Group meeting conference in Orlando this past weekend, and that group is doing a lot of work on regression, and they've got some research out on possible treatments. So they're looking into psychiatry, immunology, neuroimmunology, and I think you can always go to the Down Syndrome Medical Interest Group website and look for the information on that. But all too often, the reason I bring it up is because so many people, young people, say in their teens or 20s, get diagnosed with Alzheimer's disease, and because they have these symptoms, which is really regression. And the treatment for that is, we're learning what the treatments are, but it's quite different. So I wanted to caution people, when somebody is so young, it's not Alzheimer's disease. It probably is regression and deserves to be assessed by somebody who knows what they're doing. Next slide, please. So here it is, the reason for the risk in Down syndrome is that it's on chromosome 21 that the amyloid precursor protein is coded, and it's associated with that protein that leads to those amyloid plaques and Alzheimer's disease. And there's also some indication that on these also genes that they're connected with affective disorders such as depression, OCD. So that's why some of the things that we see and know, experience and work with and support people are also on chromosome 21. Next slide, please. So this really goes into percentage and at different ages. So you can see that, it's not as many people in their 30s, and it first shows up most in their 40s and 50s and so forth. And so I think that also helps us to kind of think about what's the person's age and what's going on. It's all part of the diagnostic process that those of us who are healthcare practitioners go through. And everybody deserves, because it really raises a degree of suspicion because of the age, where people are in their ages. It's not to say they can't get, and there's been sporadic reports of younger people, but we need to look at other kinds of conditions that may be going on that may mimic dementia. Next slide, please. So here are some of the other ones that we get asked about all the time. So what about cerebral palsy? And look at all of these secondary conditions that people have. And although, there's no clear links to age-associated neurodegenerative disorders, but some people with CP tend to experience memory loss, but they're also at an increased risk of certain conditions like stroke. And a lot of these things can result in vascular dementia. And some of the docs, the researchers, attribute it, they explain it's these comorbidities that are risk factors, and that they also can contribute to the cause of dementia. Mark Peterson, who's a doctor, specializes in CP in Michigan, proposes that it's that oxidative stress. Remember those stress, the allostasis and the weathering, that and inflammation that cause risk factors. And they may be putting people with CP at a risk, but not necessarily will get dementia. But this is the kind of thing when people ask about, well, are people at higher risk? There's so much that comes into play when you're considering this. And then, I'll just point out, I'm not going to look at all these. The other thing is Fragile X syndrome, which is another genetic syndrome, is that people that are high risk because of this syndrome to have a neurodegenerative tremor and ataxia condition that can also cause Parkinson, executive deficits, function deficits, dementia, etc. So these are the kinds of things with some of the syndromes that we know about. The next slide, please. So this is the point, the autism is what we get asked out a lot. And so the underlying etiology is so heterogeneous, and many adults with syndromes such as tuberous sclerosis complex, Fragile X, Rett syndrome, and other genetic anomalies, even Down syndrome, like 16% of Down syndrome probably have ASD or have the characteristic signs and symptoms or characters, but they may not carry that diagnosis. And that being said, is on autism, the literature is really limited, and frankly, it's all over the board. Some studies have pointed out to the earlier onset of dementia among adults with ASD. They also are at a high risk, as you can see here, different kinds of medical conditions, diabetes, hypertension, seizures, which puts neurotypical adults also at risk factors. And there also have been results, reports of that. Some studies say that these adults also are protected from age-related cognitive impairment. There's some recent report that reviews people with autism may have vulnerabilities in memory and memory brain structures, but not everybody. It shows memory structures decline at a faster rate than average, and some may also have at the baseline smaller hippocampi and impaired structural connectivity, and a thinning of the cerebral cortex, especially in the temporal lobe, which is responsible for memory and language. So I think we need to kind of consider these things and take it in the big picture and context. So I think the jury's still out on that, but we're trying to. I'm on the board of the National Task Group on Intellectual Disabilities and Dementia Practices, and we're really trying to look at addressing autism and bringing the information there. And there's a number of resources on our website to go on all of these entities. So next slide, please. Okay. I'm not going to get into this. You've already had this basic. So, and as it is for it, this is for everybody, that this is what dementia is, isn't it? Next slide. And the point about it is that, there's so many things that can contribute to or cause dementia, and different kinds of diseases, different kinds of conditions, head injury, et cetera. We had a lot of people who would do a lot of self-abuse with their heads. And so they may have been at a higher risk for dementia. Some seizure disorders like Lennox-Gastaut may also make a person at more of a risk for getting dementia at younger ages. So we don't know, and there's not a lot in the literature that documents this. So it's important to know if we can figure out what's going on, because it really has a lot to do with our support systems and how we can work and plan for the individual. Next slide, please. So the continuum continues, and that's what I think about. And interestingly enough, I just used to have the figure on the right, early, middle, late, and but then because of the more and more information that's coming out, I added that on the left, which talks about where research is headed and it has implications for treatment. And the points of most efforts are looking at, you can see this pre-symptomatic phase. And it doesn't have immediately effect right now. I mean, although, for people with ID, for all of us, the newer meds, the monoclonal antibodies, that's what they're hoping to maybe look at earlier on in the disease process and making a difference there. But I'm not going to get into all of that right now in this presentation. I'm going to review the here and now. Next slide. So the point, I just wanted to point out that with people with IDD, the differences may be more in the earlier stages. And in the bold, you'll see what we found in people with IDD there are more issues with. And for people with Down syndrome, there seem to be less reported memory issues, but as compared to the more reported personality changes. So other reports, and I've heard that from the docs at the Down Syndrome Medical Interest Group, are issues around gait apraxia, which is that people have a real hard time in moving with skilled movements, even though they still had the ability and desire to do them. They can be leaning towards the side. There's a lot of things that may be a little different with people with Down syndrome. The other striking point is that oftentimes people with Down syndrome early on in the disease will develop seizures. And they can have all kinds of seizures, and they can also have myoclonus, which is the sudden jerking. So that has a lot of implications, as I say, for supporting people and also for treatment. So to be aware of this, that this is important. Sometimes I've seen people that their first sign and symptom was a seizure when they've never had seizures. That's something I think we need to, if we look with and support people, is to be aware of that. And one thing I always tell people to document, being very clear. Don't just say seizure, document what actually happened with that person. Because one of the points that I put on the other slide, that people with Down syndrome are high risk for having orthostatic hypotension, meaning that when they get up, their blood pressure drops, so they may fall. So if a person falls, sometimes getting a good description of what happens, because whether it's a seizure or whether it's orthostatic hypotension, the treatment and the management will differ. So to be really clear, when you're doing take good documentation, be good observers. Don't just say it's a seizure or they fainted or something. Write down everything before and after what happened. Next slide, please. So what does all this mean? You know, I just want to reiterate that the research isn't really well organized for a number of syndrome and genetic condition. And in terms of risk, and numbers, we don't know. So careful detection and the process to evaluate is essential. Next slide. So for people with ID, I'm going to just point out here, you know, that the early warning signs may be unrecognized, overlooked, or dismissed, and that the variations on standardized screening and assessment instruments that exist, they're applicable to people in the general population, are inappropriate for the people we work with. But we stress to obtain a baseline on that person because it's that change from the baseline, which is the cornerstone of a diagnosis. And changes in the behavior that are attributed to dementia may be possibly related to some of the other causes, such as those physical issues that we talked about. It's critical because it really is important to have this information and be good observers and good documenters. So the baseline is essential for a person. Next slide. So this is something that in terms of the baseline, getting it on, and we recommend that a baseline is done for people with ID, for people with Down syndrome. And I personally, I mean, it's the NTG says 40, but I think age 35, when people are at their personal best, to get a baseline of all of these areas that Dr. Moran talks about here. And then follow that over time. And for other people, maybe 40, 45 for people with other kinds of intellectual disabilities, because it's that change from the baseline that's going to indicate that something is going on. So, and I listed these. She has these listed in the Down syndrome, the Alzheimer's disease and Down syndrome practical guidebook for caregivers that is listed in your bibliography at the end of the slide. And also she wrote an article for the Mayo Clinic Proceedings and talks about that. So, and she follows these areas, which are at the baseline, and looks at them in the present time in comparison. Next slide, please. Okay, so this slide is kind of interesting, and you're going to be clicking down to report it. So this is her thing. You can just keep clicking down how Dr. Moran, who's a great geriatrician, looks at what we're going to do, okay, with how I assess somebody if they come in and they're either a change or somebody is suspicious of dementia. And this is what constitutes a good assessment. It's taking a thorough history, paying attention to red flags, historical baseline of function, with family members or somebody who knows the person, comparing current functional level and emotional level, you want to say, with baseline, and dysfunctions of age, looking at that, and then looking at medications, of course, and family history, if there's any, especially if there's a history of the first degree relative with dementia, and other destabilizing influences in the person's life, such as leaving family, death of a loved one, constant turnover of caregivers, and that can trigger mood disorders, which look like dementia, and looking at safety issues and cross-referencing in terms of coming up with a diagnosis. The point that I want to make here is that everybody deserves a thorough workup. And I have seen and heard of many with Down syndrome just getting diagnosed with Alzheimer's disease because they had Down syndrome. It's not appropriate. And because, as you see, there are many conditions, especially with Down syndrome, that could appear as Alzheimer's disease, but really are correctable conditions. Next slide. So this medication, I can't help to stress that because, and this is from Dr. Moran's article about all the list of medicines that can have worsening cognitive function in people with and without dementia, and also for people with and without intellectual disabilities. So consider that. And I can't help but stress to get a review of medicines. If you're thinking the person suspicious for any kind of dementia, getting review of the medications by a pharmacist, that's essential. And here in Massachusetts, we actually have the Executive Office of Elder Affairs has actually funded the Mass College of Pharmacy for a program that that they can either kind of work with families, older families on when it comes time for their Medicare renewal, what's a good program to get for Part D. Or the other part, which I think is really exciting, they have the availability of a geriatric pharmacologist. That's a pharmacist with additional clinical training who can do a med review for you over the line, electronically. So this is an excellent option and resource for people, at least for me in Massachusetts. And your state, Ohio, or wherever you live, find out there might be something like that available for you. Next slide. So differential diagnosis, and what else could it be? You know, what causes this change from baseline? There's many, as we saw, secondary conditions. And, you know, one of the things I think about, people with Down syndrome often have early cataracts, and they can have wax in their ears. You know, they've got narrow ear canals and dry skin, so they get all this wax in those little narrow canals easy. So that can be causing changes from the baseline. And I want to point out that life events are also significant for people with Down syndrome, because as Brian Chicoine, who's a doc who runs an adult Down syndrome clinic in Chicago, points out, that people with Down syndrome are really emotional sponges and are really sensitive to feelings and the feeling tone of the situation, and actually could extrapolate an issue and become quite depressed. And I want to encourage you, you can see on the other one side of the slide about that book and mental wellness of adults with Down syndrome. This is incredible. It's a great book. I use it all the time, and it's out of print, but Dr. Chicoine and Dr. McGuire have now put it online free for people. So I highly encourage you to go there and read up, because that really gives you a better picture about people with Down syndrome and help you to understand, not just in terms of diagnosis, but how to support people with Down syndrome. Next slide, please. So challenges. Oh gosh, you know, I mean, people may not be able to note challenges themselves, you know, and then, you know, for a person, their deficits may be more severe before they talk about it, or they never talk about it, or we don't even notice it. You know, for instance, you know, some of the early signs with executive function, the typical kind of things, the people we work with may have not even developed those kinds of skills to begin with. So you can't use those. And again, as I said, that, you know, the baseline tools in the general population aren't relevant, et cetera. And the issue around diagnostic overshadowing, we'll talk a little bit about diagnostic overshadowing, is meaning that when healthcare providers will attribute what's going on with a person with their intellectual disabilities and not to possible emerging dementia. So diagnostic overshadowing can work in different ways too, where they think that there's nothing going on, and there really is something going on, or they attribute it to something when it's not something, but it goes a lot. It really can be kind of complicated. So, you know, we also, you know, look at settings. People can be in all kinds of settings, and there's a lot of movement and changes in staff. So that really can complicate the diagnosis. Next slide, please. So here are some tools, and here's some things that you can use yourself in terms of helping you to get information for an assessment, a good assessment. So this is the EDSD. It's free online. People, direct support and families can fill it out, and it picks up on a number of things. And it's used to provide information to the healthcare provider on function and begin a conversation leading to a possible assessment and diagnosis. So it's in many languages. You can even download it. And it's also, I think you get one that you can fill out electronically online. So this is something that the EDSD, and it's been validated that you can use and take yourselves for your, and all, not just Down syndrome, for anybody who has an intellectual disability. Next slide. So this is another tool that, as an offshoot of the EDSD, that does serial assessment of function in dementia. And this is post-diagnosis. Again, it's like the EDSD, and it really works to help people if once the person is living, it kind of to assess for what supports are needed when, and even the effects of treatment. Say if you started Namenda or Aricept, what happened, you know, what are the effects of the medication? Or, you know, if somebody moved, if you can go back, somebody may have moved in the house and is causing a change in the person's status. So it's another tool, and it's available for free through the NTG. Next slide, please. So the thing that over time that I always have kind of been amazed, or kind of thinking about is like change in focus. You know, I've worked since 1976 with people with ID, and we're always about learning new skills, you know, independence, you know, choices, stimulation, community outings. The more options people have, the better. And really do. And we use behavior modification quite freely. Whereas after the diagnosis, this is a real change. It's maintaining function and social interactions as much as possible. It involves with a lot more hands-on personal care, which can be challenging for some direct support professionals, and they're not used to it. And it's different kinds of thoughts that go into the activities you work with the person. Predictable, consistent routines, the environment figures in, limiting choices. You know, sometimes we talk about community outings. You really need to be a little bit thoughtful about what community outings people go to. I've had a lot of people who have gone on vacation for a treasured vacation, and have had issues on the vacation in Florida or somewhere when they're living with dementia, and they just unfortunately cannot manage where they are in the disease process. And that can be pretty upsetting to those of us who provide support and care. And it really is, we really need to focus more on feeling and being. And many programs I've found that are really goal directed, you know, a lot of like day habilitation programs, you have to write, you know, your plans, and they have to have certain goals for doing certain things and measurable goals, etc. And a lot of times with dementia, at best, all you can do is maintain. And where I look at figuring out goals, maybe looking at much more goals around how people are feeling or what's going on in, you know, in terms of their lives, and try to minimize distressing behaviors on people. And I think the difference can come up when you develop your strategies as part of your goals for somebody living with dementia. So, I mean, the most important thing is that keeping the person active and engaged in a way, but a little different, that because we need to keep the person with us, because relationships still matter and that connection still matters. And it's these outside connections that are essential, because inside our brain, you don't have those same kind of connections going on. So we really rely more on that. So we really need to focus on feeling or being, not just doing. Next slide, please. So there are a lot of issues for families. You know, there are issues in terms of, it goes against, you know, having a child who now is living with dementia goes against the natural time frame. I mean, you've worked a lot, and most of these families and staff really put a lot of effort into having their child, their sibling, grow and be the best they can, and these efforts over years. And so now with these goals, you know, the opportunities, it's really pretty it can be really sad for a lot of families, and just doesn't make sense, and can be really difficult for families. So grief is something that is quite normal for a lot of these families. The other thing is that for many families, you really have to be quite the advocate for your person, even, you know, with something like this happens. You know, for instance, partnering with medical community. We often talk about that. The DISMIC talks about that. Only 5% of people with Down syndrome get their supports from Down syndrome clinics. Everybody else goes to their PCP. And what do PCPs really know about dementia and people with intellectual disabilities or Down syndrome? So you need to become informed yourself. So it benefits your family member, and in turn benefits the person living with dementia. And don't forget, you know, take advantage of support groups. I myself facilitated an online support group for families of somebody with ID who's living with dementia. And it's been great, because the trajectory or how we have our lives, if you have somebody, you're a family member of somebody with dementia, doesn't quite meet with other supports groups for people who are living with dementia. So that's you know, take advantage of those kinds of things and learn as much as you can. In fact, we have in the NTG have quite an active family support group and committee that's looking to support families. So you know, that's another resource for all you families out there in terms of how to support each other and where to go and get help. Next slide, please. The other thing, and when I talk about care of or management of or supporting a person with ID in the world, I remind staff and families that they really have a bunch of skill sets already. They understand the need to consider the environment. You know, one of the things I think about is that if you want somebody to pay attention, you know, when you're working on a program per se, you gotta limit distractions, so you know these things already. I think that really be kind to yourself and realize you do know things. The other thing is that about they know about the ABC approach with behavior assessment. And the only consideration I would want to add here is the consequences in terms of you need to, one consideration is that you may more actively, as a direct support professional or a family member, might have to actively change your behavior, because that's what's going to make the difference in the interaction or what's going on with the person. So remember that you know about how to support people who have disabilities. So that's something to take some stock in. Next slide, please. I can't help but to kind of stress about the issue with pain and dementia and how you assess pain. And we have skills in the ID world, how to assess pain. Again, I would strongly advise that for people with IDD, you need to get a baseline document of how they experience or what they show for pain. Because again, just like with function and baseline, it may differ for every individual. There's a great tool, and you have it in your resource, called the DISDAT, and it's actually started out in Northern England for use of people who had severe intellectual disabilities on pain assessment and or pain or distress assessment. So that's something I would advise you to kind of think about when you try to work with people. And pain is terrible. I mean, it really is important, because we need to be proactive regarding the effects of any treatment and prophylactic treatment. And you need to have almost like a toolbox of treatments. And I think, getting a palliative care consult, which is based upon comfort. It doesn't mean treatments people can't get treated for things, but they're the experts, in terms of comfort for people. Maybe getting a palliative care consult one time to kind of help you to kind of manage that person's distress levels. It might be beneficial. These people know comfort type care, and it includes non-pharmacological treatment. So that's something that I think we don't often call into play for many of our people. Next slide, please. So again, I'm back and forth here, so bear with me. And this is the Healthy Brain Initiative for people with IDD, and we're looking at this, again, using the lifespan lens. But the reason I am putting this in and talking about it is because I want to focus on those areas on sort of the right, or areas that promote brain health, but more appropriate for all of us. It's appropriate, and importantly, well-being. So we look into all these things, and this is more of a review, but they also have a lot of, the Health Matters program at the UIC has a lot of information with regards to the healthy brain across the lifespan and risk factors, but they also do a lot with regards to people with IDD and dementia. So next slide, please. So this is the point that I wanted to bring up, and I'm finding more and more when I'm doing a consult with somebody who's living with dementia, I also bring in about these 6 pillars of health, because they all need to be reviewed or considered when we look about well-being. And so I talk about that. And so, for instance, people need to move, continue to move too, even if they are living with dementia. And there's all of these things. But the medical health one is interesting for me, because I'm going to just use that as an example here, is that one strategy is making sure a person's vaccines are up to date. One point I thought about is like, oh my goodness, let's take shingles. Can you imagine somebody getting shingles when they are living with dementia? What does that mean for the individual? So there's a lot of things that I think we need to kind of consider and be aware of. And pneumonia shots, now the RSV, the newer shot that's coming out for adults. So, bringing things up in the conversation. Of course, it depends on where the person is living within the continuum, because over time, as disease progresses into end stage, there needs to be conversations regarding treatments as to necessity and benefit. But we need to keep those communication lines open. Next slide, please. So this is one example that I did a talk for the UIC about well-being. And this is one when I talked about sleep and relaxation. And, we do know in people who are living with dementia, their circadian rhythms are thrown off. So whatever we can do to return it to baseline, the better. I didn't add here, but I think it would be beneficial to stress management ourselves. It's essential with caregiving because the caregiver's stress is easily communicated, however unintentional, the person living with dementia. So looking at ways also for yourself to minimize stress. And that goes back to a lot of the other components of 6 pillars of health. Even easy mindfulness strategies can help here. I mean, there's a lot of work that's being done on light therapy, looking at how that can benefit changing your circadian rhythm. And also for some people, it's limited, but information about how it affects depression and stuff. So there are a number of things that sleep is the time also that we get rid of all that waste matter and garbage in our brains. So having decent sleep as much as possible or enhancing that's important. Next slide, please. So I cannot help but to highlight this life story work. And it's a tool that I always invite teams to utilize. It's perfect and meaningful activity for family members if the person lives outside the family home or even inside the family home to engage with. It can take any form. There's a number of forms online. If people are interested, you can contact me. There's stuff in the UK about doing a life story. And it's almost a memoir about the person's life, what the person likes, not likes, personal stories from the past, along with pictures. I'd say I would also advise, and these are some practical tips, label the pictures. If you also include with the picture a story about the picture. So if you engage with the person, you can do some reminiscence and talk about things. It's a perfect way to engage, a person-centered way to engage with the individual. Because, as the disease erodes more recent memories, it's these past memories and examples and connections that keep us connected. So, but even if the person is living with you as a family member, do that because, you'll have this available to your respite providers or somebody who may come in and provide individual supports in your house. And that kind of gives some a real flavor about the individual. The other thing I talk about a lot is the use of sensory-based strategies too. For instance, if there's smells that have meaning, for people who are Italian, maybe the smell of tomato sauce cooking. I don't think they have tomato lotions or something, tomato sauce lotions, but other kinds of fragrances also can be effective in helping people. If the person's mother's perfume, Gouet de Bois was something that that I could think about. My mother never wore perfume, but some parents at that age would wear certain perfumes. Music is essential. We all know the benefit of music. I tell people have a playlist, with both the quiet ballad tunes, to use if the person is agitated. Say, for instance, a lot of people are Elvis Presley fans. Love Me Tender. However, use that jailhouse rock and all those other forms of music when you'd like the person to stay awake and interact. And more personal ingredients to your toolbox include recordings of family members, reading, maybe singing a lullaby. One niece and I worked with early on, she remembers her own mother, and her mother had a sister with Down syndrome, reading Bible stories to her sister with Down syndrome. And so when the niece visited her auntie with Down syndrome in her group home, she would do the same. She'd bring Bible stories and read it to her aunt. So afterwards, when her aunt developed dementia and was living with it, she recorded her reading the stories with this. And staff, when her aunt was agitated, they would play her niece reading these Bible stories. She may not recognize her niece, the image. If she met her niece, she would not recognize, but the voice patterns are still the same. So she did recognize it, and they found that it really helped to soothe the person. So other things, tangible kinds of examples include Special Olympic medals. Having the stories that go with them, because you can bring this out and make it much more meaningful, and that's a tangible thing. So there are many examples, and most of these are really cost effective and don't cost a lot of bucks. And I think in this day and age, we're always looking for something that's not going to break the piggy bank, but they're really meaningful connections and can help guide our strategies and greatly enhance the person's well-being and maintain relationships. Next slide, please. So planning, and there are a number of tools in the general community about planning around Alzheimer's dementia, in terms of what happens physically. So if we can use times with people with IDD to kind of, how do we figure out what they would want if they had something happen to them? One thing it's dynamic, it's not a one-time activity. And so looking at some of these in the red, the life stories, values, preference, cultural context, a lot of people, with ID will, if they're in the family constellation, their feelings and desires of what they would want is the same as their family. That kind of feeling tone is kind of like in the blood or something, if you want to say so. And we know a lot of people, if given a choice of what they would want, they would tend to go with, ask their families what they would do. So, however, that being said, I think being proactive as much as possible earlier when concrete situations present themselves is beneficial. For instance, my friend Bruce, you saw his picture, and my mom had probably a mixed dementia. He experienced my mother's dementia. So we talk about what happened, and he has something concrete and understandable about what dementia had been, at least for my mom. So we'd be getting to talk a little bit about that. So, and, Dementia Friends here in Ohio, you developed something for people with IDs and great proactive activity to kind of explore things with people so people can have that. The other thing, if there's situations that do present themselves, is to, document what happened, the results of what happened in terms of what that person would want and desire, if they could articulate that. I'm recently asked to visit a brother and sister, both with ID, because their mom is now living with dementia and they don't really understand. So this will be interesting for me to go out and kind of spend some time with them in terms of understanding what it is with their mother. And I think we're going to be finding this out more and more. And how do we support each other? Next slide, please. So treatment. And I have to point out here that people will say that there's no treatment for dementia. And I always remind staff and families and others that really you're wrong. There is treatment. It really is you. And what you do and who you are makes such a difference. That is treatment. That is treatment. It may not be a curative treatment, but it is treatment. So remember to consider the value of who you are and what you do. It's important. You make quite the difference. And again, looking at these kinds of things, and I always talk about, it's so important. Kathy Sursick-Storr, whose brother had Down syndrome and Alzheimer's disease, pointed out in the Aging and Down Syndrome Guidebook about these kinds of communication, collaboration, coordination. We all have to remember these kinds of things, and communicating is essential for this. Next slide, please. So future planning is important. It just takes some time, look at all, these are things that everybody needs. I mean, monitor our feelings, have a plan of care, working together, focusing on the individual. You have to be realistic, get the facts of the situation. One of the things that I also talk about is that for staff, in terms of support and things like that, one strategy is, when you have your house meeting, carve out a small portion of that to be your support group for staff. And even in some places, and you'd have to kind of figure out with your human rights committee and, with HIPAA and everything, you can include some of the housemates in the discussion about all supporting each other and how we support the person who's living with dementia. These are just some ideas that I've tried and percolated over time. And it really depends on the individual, the situation, and a lot of things. And of course, we all have to consider legal mandates where we live and work. Next slide, please. So here are some resources, and they're really great. Most of them are free. Oh, Anne Has Dementia, Beyond Words book series is that it comes out of the UK, and you have to purchase it, but it's something maybe for people with autism or other places that might be beneficial, and maybe a little higher functioning people to do storytelling. But a lot of these things are available and they're free online for you. So do take a look at them, and they're in the resource and sort of the later slides. And the next time. So, again, I talk about, I think those of us, we have a lot of statutory requirements and what we can do and how do we balance. And when we have people around. And, these are considerations we have to consider when we're working with people. And, our peers and housemates, what do we do about that? What do we tell? What kinds of things do we say to people? So all of this, but the point what I'm trying to make is have this conversation beforehand and thinking about these things. And nothing, there's not one size fits all. So I think we need to take that time with each other and work together on these things. Next slide, please. I'm going to pull my, is that building relationships is essential. My dog wants to come out on my lap. So it's really important. You've got something great here with the Ben Rose is developing relationships with different agencies. Even, this morning I was volunteering in the senior center coffee shop. Sometimes I bring my friend Bruce to there when I was volunteering regularly. So people get to know you. We can call people up and get information. Some of our Alzheimer's Association, faith-based, a lot of things. And, talking to people, figuring out on, I'm on my hospital ethics committee. I'm also on the board of directors of my area agency on aging, because then I have some connections and you can reach out to people. So these are important depending on where you are in your life and your availability, and finding these kinds of things and finding people that if you have a person to help you navigate. That's the thing that I think can be difficult for family and direct support professionals is navigation. So figuring those kinds of things out and having somebody that you can trust to help you with this. Next slide, please. This is something I developed when we did I was part of the International Symposium on ID and Dementia in 2016 in Glasgow. And I was looking at the end of life kinds of things. And I was thinking about trying to develop something with regards to hospice and palliative care and ID. And this was something that I drafted. I mean, it was never used, but it's like what each area is bringing to the person and who the family, caregivers, and kinds of issues that we have to think of. So one thing is, we do know that it is a continuum, and it ends in death. So what can we do? How do we work with hospice and palliative care? Not all hospices are the same. Finding people you can work with and work well with is a key. Next slide. So what do we know? It's moving to an end. It's a constellation of symptoms. It's caused by disease and conditions. We know some people are high risk for it. We don't know. I did a lot of discussion about some of those other IDs, and the research is all over the board. And if we and some of us who are interested in ID and dementia can kind of help to gather these things and make sense of them, we're glad to do that. And in fact, we're having another international conference in Toronto in October. So there's a group of us who are going to look at neurodiversity and trying to understand how do we address that for people with IDD. Again, it's a continuum, and it is a progressive condition. It ends in death. But look at the person, the life story. Who is this person? What matters to them? What can we do to support each other? The value of a baseline is essential because we cannot use those tools. So having a baseline from which you can evaluate what's going on in the person will be essential in terms of the assessment and the diagnosis. And where's planning fit in? And planning, again, it's dynamic. It's not one place in time. And how do we understand that? I can remember going to one of the consults with Dr. Moran, where the parents who were the shared living providers, their daughter was being assessed for possible dementia. And when Dr. Moran said, I think she probably has Alzheimer's disease, they needed to get some more testing, except the parents were like a deer in headlights. And I just felt for them. And how do you understand what supports were available at that point? The other thing I wanted to kind of say that, primary care providers can do a lot in terms of assessing people for correctable conditions. If you suspect there might be Alzheimer's disease. So getting certain tests like a thyroid function test, B12, et cetera, looking at other blood work, getting that early on in the assessment process will be really beneficial. So even when you go to a specialist, you already have that information. You won't have the specialist saying, well, get these tests and then come back in 6 months. It would be really beneficial to have a lot of this information beforehand. And if the people have questions, they can talk to me about that. So the last thing I want to end here is that death ends a life, but not a relationship. So the value of the life story, I talk about that, these pictures, etc., at wakes and funerals, having these kinds of things are really essential. They commemorate a life, a really important, valued life. And that is, people deserve that. And we deserve that, having that with the people we work with. Next slide, please. So thank God, the last PowerPoint. So I mean, I am kind of a silly person. So one thing that on the picture, you probably figured out that's me, and that's my friend Bruce, and he turned 82 last year. And so he was having a birthday party at the bowling alley. So I talk about the senses, and one thing is that we know that a lot of our senses decline, all the ones from vestibular, proprioception, hearing, vision, blah, blah, blah. But the one sense I tell people that doesn't decline, it doesn't need to, is that sense of nonsense. Have a, I mean, it's kind of like we're talking about something that's really not very, very happy, but, have that. It gives us, be silly about some things. I mean, with people as you can, because that gives you, it lightens your load somewhere, and it's okay. So take advantage of kinds of silly things. With my own mom, I had some situations that at the time was like, oh my gosh. But as I talk to him now, I mean, and right after the fact, I got, I'm kind of laughing about it because I'm supposed to be the expert in what's my mother doing to me. And so much for the expertise. Next slide, please. So these are part of, actually, this is part of my, I've been doing the Dementia Friends training for people with ID. Thank you to people from Ohio for your initial work on it. And these are some of the resources that we have. So this is relating to Down syndrome. And next slide, please. And then there's that tool, the DISDAT tool for assessing pain. And the UK, I love what's going on. They're really progressive around dementia capable care there. And they're doing a lot of work for learning disability. That's the term in the UK for intellectual disability. So there's a number of resources available there. And I was going to put a little video in here with Cindy Bentley, who's a woman with intellectual disabilities, talking about her friend who had Down syndrome and developed dementia, and the experience it was for Cindy. For the lack of time, I didn't leave that there, but what I'm going to do, this is available on the Mind and Memory Matters website, but when you go in there, you have to kind of search for it, and you have to go under videos and then click on it and scroll all the way down, because you should review that video yourself. And it's really, it really gives you a good idea about how people with intellectual disabilities may understand and what they feel about dementia, especially when it's occurring for their friends. So I think that that's an important thing to have for you all. Next slide. So I always end my talk and just saying, to the families, and these are some people from, I got involved with people with ID and dementia back in the late 1990s, because we were having people with Down syndrome who all of a sudden had dementia. We didn't know what to do. So that's when I met Dr. Matt Janicki and Arthur Dalton, and started to learn about Alzheimer's disease from people in the Alzheimer's community, and then learned how to modify or whatever for the population of people that I've been working with. So all these people, when I look at their names, I can think back on all the situations and I had. And one of the things is that you all are my greatest teachers. And I mean it with all my heart, that I really have learned a lot over time. And what you have done and what people have shared with me this is your legacy. So that painting in the bottom is something that Bobby, who is a woman, one of the first people that I met who was living with dementia, had done. And I actually thought it was so beautiful. I even got some fancy paper, this watercolor paper, and commissioned her, to do some paintings for me, because that really has a lot of meaning for me. So, using the arts and stuff is important. So I'm just going to leave you with this. And there's a lovely quote. I'm not going to read it out loud on the bottom that says, we really, about being kind and being treated decently. And that, we want people to see us, and we want to matter. So I thank you for your time and your patience with me, and thank you for all you're doing. Thanks.
Well, thank you so much for an insightful presentation, Kathy. We have time for a few questions from the audience. We just want you to remind you to submit your questions using the Q&A feature at the bottom of your screen. Just to clarify with one of the questions about the handouts, are those listed in the resource slide that you provided?
I'm sorry, say again?
The handouts that you were referring to in the presentation, are those linked on your resource slide?
Yeah,
Great.
they're in the resource. Yeah.
Great. And then another question that we had was, if the person with Down syndrome is diagnosed in their 40s and 50s, is that still regression?
Yeah. Well, I can't say it isn't, but I think, again, that's where the diagnostic process comes in. I mean, it's possible, but I think that what's going, it may, but usually at that, as you approach that age, and again, looking at what the history is, when did this happen? What's going on here? And that's why, having, if they first started showing that in their 40s or something like that, it's probably highly unlikely that it's regression at that point, to be honest with you. But I can't say it wouldn't happen, but again, every individual is different, and that's the clinician. It's the person who does the assessment can help you to pick this apart, what it is and what it's not. So I would probably say that it more than likely may be Alzheimer's disease, but again, without all the big picture on what's going on with this person, I would think it's highly unlikely. Lots of times regression can be in response to something happens. And if you really look back on things, you can say, oh my goodness, they had this or they had this happen. So that's the kind of thing that where good history is really essential.
All right. We had a question. What are your best tips for helping care providers change focus of care after a diagnosis of dementia?
Well, it is hard. I think, one of the things is just to kind of chat about, in terms of it is, the brain, what happens in the brain. I mean, what we're talking about is that there is damage to the brain, and how, what happens. And, not that we don't want people, and this is one, I'll give you an example, to also have excess disability. We don't want to contribute to more disability. And I can remember this happened to me one night. I went in 11 to 7 in a group home, and, the third shift, they have to get people up. And they, at one point they said, well, what can I do? What if Judy can't put her coat on? So, we look back into using all these strategies about, here's your coat, Judy, pointing it out, gesturing, put your hand, through the coat. And depending on how she follows things, you might actually take and physically guide her hand. And, you kind of build up to these kinds of things. But I think the hard thing is having a conversation about, this is there is brain damage. People may not be able to learn new skills at some point, and I think that that's the hard thing. I just worked on another grant, and people were really upset. They're like, oh my goodness, I mean, I can't. It's not to say that they not necessarily, but it's a lot more difficult. And I think as a result, if we're expecting people to do things and they can't do it, it's frustrating, and it's also for the individual themselves, it's not very comfortable for them. They will become distressed.
All right. I just wanted to quickly answer a question. The slides will be available for download in our resource library. All right. I have a question. Can you talk a bit about the diagnosis of AD and DS through biomarkers?
Oh, goodness. Well, there's so much, my gosh, that's being done on that right now. In fact, the National Task Group worked with, I cut this out, but with Lumine, which is an organization in terms of research. And they've actually, if people are interested, you got my email there, I can send you the link, and it's actually available, that document about people with Down syndrome and the use of some of these monoclonal antibodies, et cetera, and how to use them safely. I mean, we have to kind of figure out, I mean, no doubt, people with Down syndrome have plaques and tangles. And if you did, get a lumbar puncture or did a PET scan on anybody, say from 35, you would see this on them. You have findings of amyloid. and probably tau. And there's been a lot more in the research about this. So in the future, I suspect we aren't going to be using all of these. We'll just be doing biomarker testing on people in terms of treatment and diagnosis of this. So I think, it's new and ongoing science. And right now we're working in the National Task Group to make it so that people with Down syndrome can be included in research studies safely. And that's the thing that we have to be sure about. But anyway, there's this huge document on the NTG website, or if you have issues, just connect with me and I can set you to go there. But we know for people, there are certain biomarkers. And I just read something that came out of the Alzheimer's International in Amsterdam, that they're also looking at biomarkers for people with Lewy body dementia, which, in that case, that woman, with her sister, I'm like, oh my goodness, I wish we had something like that for her sister. But so I think over time, these kinds of things are going to be coming more and more in the front. But people will have Down syndrome. They are already known to have certain biomarkers for Alzheimer's disease, but outward clinically don't show the disease. And one thing several years ago, I remember going to a conference and they're figuring some of the signs. Well, what's the trigger that makes them all of a sudden start to show outward symptoms? And there was some discussion where there might be inflammatory processes that might be the trigger for people that turns over the steady state into the development of clinical signs. Again, there's so much research being done and out there. So just stay tuned on some of this stuff. In fact, I think the National Task Group, we did this webinar series about aducanumab, when it first came out, but we wanted to do a follow-up on some of that stuff. So you pay attention and with that, and I'm sure we'll let you all know if that happens.
Thank you. That was very interesting.
Oh.
I have a question. Many caregivers / family supporters of people with IDD are aging themselves. What have you seen in terms of parents, other family members developing dementia? What can services do to support people in these situations?
Well, I have seen, and it's interesting, and I'm not sure, exactly, but oftentimes there'll be, if you have somebody with Down syndrome, the mother will, or some family member will also have Alzheimer's disease. And I think that, careful discussion of things, including families, it's not easy. I mean, I think one of the things is, to try to develop a relationship with these family members and trying to figure out where they're coming from, what they understand, and understand what's going on with their family member. It can be a real challenge. I mean, for people, with who are living, having dementia. So, again, this is also where you have to work across the silos, the aging and Alzheimer's networks, and also the ID network, because, I've had situations where the mom is getting supports from the aging network, and the child living at home there gets supports from the ID network, this organization, and they don't talk, they don't do anything. So let's figure out, let's have a discussion and have a meeting about how do we work together and who does what about some of these things, and looking at that. I mean, it's not easy. The other thing is, even when you can always have other families who have a child with ID and dementia. Families are great. They will reach out to each other. I mean, many times from the family support group that I facilitate, oftentimes I'll have a few families who will gladly reach out and individually chat with another family member. I think sometimes it's much more meaningful to have another family speak with a person, but it can be a challenge. But I think the important thing is that collaboration, communication, that the little thing to keep those lines open, because it's also, we so work in such silos. So developing relationships where you can work together is essential.
Thank you. And then I have a question, if there is a registry of DS clinics by state or nationally.
Well, the Down Syndrome Medical Interest Group is, they do have, you could go online and they have a listing of the clinics. So I'm sure that they would be the people who know that where the clinics are available nationally. I know that. So they have the listing, and it's interesting because they also have a listserv. So there'll be a list. I have somebody in this state, where can they get services? And be aware that sometimes, some clinics, you cannot, cross state lines, or what does that mean? That's also a consideration. There's a program, Mass General Down Syndrome Clinic has Down Syndrome to You. And although it costs, you can electronically, fill out forms, and somebody at Mass General in the Adult Down Syndrome Clinic will do an assessment, like electronic, and make some recommendations to you. But that's another option for people, because again, many clinics you can't straight lines, you can't cross them, especially around payment and things like that. So.
Thank you. And then I had a question. What are some strategies that you can use to support the emotional health of people with Down syndrome? You mentioned that in a handout earlier.
Yeah, well, I think, some of the people, it's really, being, using, those kinds of senses that they work best in, sometimes visual sentences, visual communication, showing people things, talking about things, people can play act and, getting people involved with things about what's going on. A couple weeks ago, I went to a baseball game with a group of people from this day program, and I was in the back of the van with, there was two guys with Down syndrome gabbing, and they were talking about, both of them have divorced parents. So listening to them in terms of talking, maybe even peer support around some of these things. There are, self-advocate groups and stuff like that, or talking about things, and giving people time. I think the other thing is that their time to do these things. I would highly suggest that you get that mental health wellness, that book. It's incredible. Brian and Dennis in there talk about some of these things, and will give you some real expert and knowledgeable strategies on how to support people with Down syndrome. It's amazing. It's really a gift that we now have that available for free.
Another question that came up, prior to a dementia diagnosis, you speak about learning new skills, encouraging autonomy and stimulation. Is there any examples you'd like to share that have been successful in engaging your IDD care recipients?
Oh, this is before the diagnosis. This is learning. And this goes what we do all the time in the ID world, writing our goals and figuring out what working with the individual and the family about, well, at the annual, every state has a different term, annual individual service plan or support plan, what the person's going to do this year, et cetera. And, you may have to, for instance, figuring out, the person's going to be much more, go out, physically active, take a walk, beforehand, like at least 3 times a week. You want to increase the person's physical activity. And so, you'll have certain strategies on the staff will remind the person, depending on the individual, where they are and what works best for the person, you'll be listing these strategies on what works best for the person. So backtrack, they get the diagnosis of probable or dementia. So how, you want them to keep that same goal. But yeah, I think we want to talk about physical activity for people. However, you may have to use other skills in terms, other kinds of strategies, like the person the staff will, take the person, work, have the person take a walk with the staff, blah, 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 or using where in the setting, depending on your house, down the hallway a certain number of times, or if you can go somewhere, or bring them to like someplace safe to walk. So it really, it's like some of those things you may have to just modify the strategies, because you really want a person to stay as physically active as possible, even when they're living with dementia, because dementia can happen. Down syndrome may be shorter, but for most people, it can by the time you're diagnosed to by the time you die, it could be a number of years. So you want to be able to also, by doing these well-being activities or intervention, you're going to enhance the quality of life and maybe extend it even for longer. So looking at some of these kinds of well-being things, but again, it has to be very person-centered. What's the individual, and who, people who know the person. I can't, when I do my assessments and meeting with the team, I'm like, well, you tell me about this person. Give me some hints about, what works good, what doesn't work good, what in the past. The person, they'll be able to tell you. And then the other thing is, like, at what point do I stop making Judy put on her coat? I tell people, take your cues from her. If she just is more confused about, then it's like, it's not going to work. You might try it a couple more times, but she may be past that point. So don't cause her to become distressed, and just move on. She's in a new phase of the continuum. So that's what you have to do. But you can often take your cues from the individual. If you know the person, you'll get a sense about how they're doing and what they, what is available still to them and what's not. But honestly, the other thing which is so hard about being with people who are living with dementia, that sometimes you're going to get out of the blue something. They'll recognize somebody or do something, and it's like, where'd that come from? There's a lot in the research being done about these, quote, lucid moments, and why that is. But you remember, our brain is incredible. We might have pockets of cognitive reserve that all of a sudden you get this message that goes through in your brain and it hits the pod where the cognitive reserve is, and it reads, and it gets read, and it's read, quote, correctly, and then it goes back out following a path line, and you'll find this happened. And I know myself, and my mother was in end stage. I was saying something to her, and she was clear as bell. She remembered my name, and she told me she loved me, which was, she never said that in my whole life. So those kinds of things, I think, are just really essential, and to take stock of that and to value, but also don't, to realize it's a moment in time. And that's the other thing about when you're working and supporting people, be in the present moment and celebrate that present moment when you're with the person.
Thank you. I think we have time for one more question. What are your thoughts on PRN meds for individuals with ID and dementia? For example, should there be less PRNs and more regularly scheduled meds for pain, heartburn, constipation, etc.?
Yeah. I think that's a hard one, because looking at, the PRNs, I'd like to think that that's why having that list of health, what we know, what happens when people get older, also the health conditions, and knowing what is part of that person anyway, with age. So, developing in a way, if you can, giving routine meds as much as possible, because, PRN is just, sometimes it's not, people don't get things, and who decides when to give something to somebody PRN? What's, I've seen what the med orders are and who makes the decision and things like that. Or does the person have to complain about things, or who decides what? So I would say, for some of the things around arthritis and possible pain, try some of these things around, according to, what, the guidelines around how much to use of, like, Tylenol or stuff. Try these things first of all. And there's some incredible, some of the other things that are being used are some of the non-steroidal anti-inflammatory creams, etc. And in Massachusetts, I have to admit, there's a lot of work being done on marijuana, medical marijuana, which this is hard because we can't use that in many of our group homes. So what kinds of things that people can use? But I think, and constipation, you want people to have a regular thing. What kinds of have some regularity, because routine and regularity, keep people on the steady state. Bouncing back and forth medicating, you want to be able to nip that pain a lot earlier and not have a person reach a point where it's not they're not going to get treated, you're going to require more medication. So I think if possible, I would advise, but again, around some of these things, especially the pain things, talk to some of the palliative care people. I really think, there are so many things. I went to a advanced practice, the Gerontological Advanced Practice Nurses Association, and we had a talk, and they're talking about some of the things they do around breathlessness and what happens if people get anxious about blowing cold air on the person's face, and how that and there's a physiologic reason, that which I can't describe right now, how it does calm the person and it makes their breathlessness less distressing to the person. So people have a lot of tools that they're experts about. So take advantage of them.
Thank you so much, Kathy.
Oh gosh, thanks.
Before we conclude today's webinar, I am going to tell you briefly about BRI Care Consultation, which is a care coaching program available for families impacted by dementia in various counties in Ohio through the Administration for Community Living project. BRI Care Consultation is a telephone and email-based care coaching program that assists and supports adults with or at risk developing dementia, including those with intellectual and developmental disabilities and their family and friend caregivers or other supports. It is available for free for persons with IDD and their caregivers and supporters for those residing within the project area. BRI Care Consultation provides equal support to the persons with dementia and other health conditions, as well as the caregiver. Caregivers work with the same care consultant to foster an ongoing relationship that provides continuity and support. We help to identify unmet needs, provide options to meet the needs, and help talk through difficult conversations. Dementia is not a one-size-fits-all disease, and neither are one's care needs. One person cannot sustain being the only caregiver, yet some attempt to do this. While not everyone is comfortable providing hands-on care, we hope to help identify some other supports who can step in to help with the ongoing tasks of daily living to take the pressure away from the main person providing support. On this next slide, we'll see a list of agencies that offer BRI Care Consultation. All right. We want to thank you again for joining us for Bridging Conversations between Intellectual and Developmental Disabilities and Dementia. A recording of today's session will be made available at www.benrose.org on the event registration page and in our resource library. We will be offering more webinars like this for community organizations and families impacted by dementia. To stay up to date on all upcoming webinars and events that Benjamin Rose has to offer, such as Aging in Place, naturally occurring retirement communities that will be held on Zoom on Thursday, August 31st from 1 to 2 p.m. Please visit our website, www.benrose.org. In the chat, you will see a link to a post-session questionnaire. You will also be receiving it via email later today. We ask that you please complete the post-session questionnaire within 1 week following today's session. Your responses and feedback will be used to show the impact of the programs like these and improve the tools and resources provided to individuals living with dementia and the people who support them. Thank you again for joining us and have a great day.